Podcast is now starting. All attendees are in listen-only mode.
Hello everyone and welcome to today's session. Today's topic is successful non-clinical data preparation and submission, simplifying the compliance with SEND implementation guide 3.0 and 3.1 in preparation for the upcoming March milestone. I would like to introduce today's presentation team. We have Avanish, Chief Technology Officer at Zybion. He's an engineer from IIT and has worked at Bentley Systems, CTS Tech, and Zybion Corp. Second panelist is Bob Friedman, Chief Technologist at Zybion. He has a background in biomedical engineering and has worked with New York State Department of Health, University Medical Center, and Synthes USA. He's also a member of focus groups within CDISC for the SEND standard. The third panelist is Carlos Frade, Vice President, Preclinical R&D Solutions. He has a background in computer science and has been a strategic advisor to research facilities across the globe for over 20 years. A recorded version of this webinar will be made available and links will be shared for download of the slide deck and the recorded version. The webinar is structured for about 40 minutes of slide deck and discussions and the 20 minutes for Q&A. We would love to hear questions from you. If you have a question, please type your query in the chat or raise your hands in the user interface of the GoToWebinar application. For those of you just joining us, welcome. Thank you, and over to you, Carlos.
Well, good morning to everyone here in the United States on the East Coast. Good early morning to people on the West Coast, and a good afternoon to our colleagues in the Europe time zones. As Nagraj indicated, this webinar, in fact, was planned several weeks ago because we have seen some challenges and experienced some challenges of our own in terms of preparing SEND submissions and wanted to share some of our experience with clients. I want to take this moment to ask the experts in the room, and I know that there are quite a few of you that are experts at SEND, and I want to ask you for a little bit of patience in the very beginning because I want to give a little background in terms of what this all means, what SEND is, for those people who are just now joining the community or now becoming aware of the challenges. Bob, I'm not there yet. Today's agenda is basically to go through the SEND 3.0 and SEND 3.1, give an overview of them. We, as both the tool set developer and the service provider, have seen challenges in terms of the implementation and in terms of generating the data sets. So we wanted to take you through a couple of different strategies. One where you have the complete solution, whether it's from Zybion or from another service provider. You have companies out there who provide both the data management system and the SEND creation system, and that poses one set of challenges or has one specific approach. A different approach and a more challenging one is situations where you are not conducting the study internally, or you don't have a data management system, or you might have a data management system but not a SEND creation system. So we're going to discuss the strategy for disparate systems as well, and how to validate the results of putting together your SEND submission. What kind of stumbling blocks we've encountered and can share with you in terms of what and how to avoid these stumbling blocks. We want to give you some references and resources on for your own experience and for your own reading and research as well. And then we're going to go through an actual demo of how we take data from all disparate sources and take them through our own tool set and provide or produce one SEND compliant data set. And then we're going to talk about how to automate further these processes, because there's a lot of manual processes that may be involved here. And at the end, we're going to go through a question and answer session. Okay? So in the first few slides, there's about 4 or 5 of them. Please bear with me. I know some of you are experts and this is going to sound really boring, but it'll get a lot more exciting afterwards. For background purposes, the send is not an option. Send is a mandate from the FDA to obtain non-clinical data in a consistent format. This makes a lot of sense for people we're living in an electronic world and we want to capture data electronically, and it would make sense that the FDA would want the data electronically, but they need the data in a consistent format. They need it with standardized terminology so that they can always look at the data in a very specific way. It's to everyone's advantage, and it's the FDA's responsibility to public health to approve compounds. And in fact, today I read an article that 2018 was a record, 59 approvals for novel molecules. This was the highest number in the FDA's history. Well, I'm sorry, since going back, I think, into the modern times, or in 20th century. I shouldn't say 20th century, 21st century. But this record was important because we like to think that by creating an electronic transformation, an electronic method of approving data and approving studies, we've accelerated the process. The article itself didn't describe specifically these reasons, but as developers of these tools, we'd like to believe them. The end result of the SEND dataset is a consistent set of computer files, and they're in SAS transport. For anyone familiar with the SAS statistical analysis tool, these are SAS compliant datasets, and as well an XML file, defined.xml, which is basically a set of metadata associated with the study. Go ahead, Bob. All right. The SEND dataset together assembles all of the study data, the design of the study, the animal demographics, the exposure, the observations captured on the study, and gathers all this up. And in fact, it's now a required component, as part of one of the modules of the ECTD. So this isn't optional. This is a required function here. And it initially, SEND 3.0, currently in place, covers single dose general toxicity studies, repeat dose general tox, and carso studies. The SEND 3.1 will actually expand the number of studies into safety pharmacology, specifically respiratory and cardiovascular studies. This is some of the examples or data types that are included in a data set. You have basically demographics of the animals, what kind of animals you're using, what species, what strain, what age, pool definitions to allow the FDA to understand how many animals were in the cage if you have a cage site observation, which animals were in the cage. If you had other types of data like lab data where you were recording everything just on one set of animals, one result, we would need to know which animals were associated with that. As well, we captured information such as disposition, the exposure rules, or the exposure data on the animals. We're going through the daily observations like body weights, observations, food and water. And then at the end, or down at the bottom, we also put together the trial design, which, for the people that aren't familiar or with the clinical side of things, the preclinical data or preclinical study design is actually transformed into a compliant set of data sets or compliant set of to match what trial arms, trial elements, trial sets, and the trial summary. Go on. I'm sorry, between SEN 3.0 and SEN 3.1, we had introduced specifically, well, not we, but the introduction of respiratory and cardiovascular data was introduced into the main data sets. All right. So I mentioned a little earlier the define.xml, and the define.xml file is number one, it's very study specific. It's created for every study. There's no one way of doing it. It actually is supposed to represent the study, much like a table of contents and an index in a book will reference chapters about that book. This data is supposed to provide information supplemental or about the actual data set so that the FDA reviewers can navigate through the data and understand any derivations, any methods, calculations that were used. And these are all things that are not obvious in the data sets themselves. Okay, so this basically becomes a little bit of a dictionary or roadmap about the study. It's currently on its second version. At the moment, FDA is preferring version 2.0. Go on. All right. I think this will be the last of the boring slides. Send is not new. In fact, quite honestly, I was involved personally a long time ago, right around the time my second daughter was born. Where the idea came to be and it was put out there. There was an initial pilot that was done, and people were actually assembling some data sets by hand in order to pursue this strategy. In 2006, but that sort of died out or went dormant for a while. In 2007, it became re-energized. And at that point, they had a subset of about 15 companies together with the FDA that explored in a more detailed and a more complete manner what a SEND data set would look like, and were able to develop the SEND implementation guide for that pilot. This became a major milestone. And shortly thereafter, in like 2008, 2009, we were mandated by our client community to start developing toolset to produce the SEND data set. The first SEND IG was actually formally published in 2011 through CDISC. Zybion was a component of that committee at the time. And in fact, later on that year, in October of 2011, is when we produced our first SEND module, if you will. The language became law in 2012, and then in 2014, the countdown began. So it was published, and 2014 they gave a 24-month setup period where everybody had to become compliant, and at that point, people started to get nervous. In the meantime, during that time, we had been working with our clients in terms of developing our tool set and getting it in a compliant condition, but we found that we were doing quite a lot of work to automate the production of the data set. We had our own version 1, 2, and 3, and then clients demanded more automation on our part rather than simply the mechanism to produce the tables and to manually insert information. They wanted a lot more intelligence and a lot more business rules built in. Just to finish the map here, or the timeline, SEN 3.0 became required for NDAs on December of 2016, and then a year later became required for INDs. You have a similar strategy there in terms of the ECTD, which became mandatory in May of 2017, and then INDs followed a year later. We generally, or the control terminology is updated on a regular basis, about 3 or 4 times a year. And we developed, as well as all the other service providers, developed mechanisms to do the updating of the terminologies as needed. Send 3.1 actually starts off, or it becomes mandatory in March of this coming year. So any NDAs that, for studies that start after March, will be required to be published in Send 3.1 format, and same is true a year later for INDs. Okay. Going forward, all right. As all of the experts that are online will attest, there's still a lot of work going on. The CDIS committees are working very, very diligently on repro studies, and having an experience knowing the variety of methods by which people capture repro data and by which they call things, I can understand that it's a challenge to normalize all of this information. So they're actively working on the teratology DART implementation guide 1.1, and then they'll have fertility and peri and postnatal developments later on. They're also working on gene tox, so the in vivo micronucleus assay, the in vitro micronucleus assay, the COMET assay, and the Ames test. Additionally, now there's other domains being defined for dermal and ocular irritations and the allocation of animals to treatments. And even for safety farm, which was introduced in Send 3.1, there's another domain being prepared for the central nervous system. It continues with working on data for studies where efficacy is being tested on animals rather than humans. And now as well, Send for the Center for Biologics, biologic evaluations, is now also determining what their differences for Send may be. All right. So we've done a little bit of background. Now all of the experts can pay attention again. The first path through, as I said, there's 2 strategies we wanted to discuss. And the first strategy I'm not going to focus too much, because in fact there's a lot of automation here. Go on. We're going to talk about the path to a Send data set when you have both the data management system and your Send system, and the 2 of them communicate. Then I'm not going to suggest that it's easy, but it's a lot less complicated, a lot less complex. You have a situation where the protocol is defined in your data management system. You have the in-life and ClinPath data being captured automatically in the ClinPath system, and postmortem data all being natively captured. The data management system can automatically transfer the data to your Send system. Go on. And then your Send system, go on, Bob. Additionally, you have some data that is not captured by the same data management system. The original preclinical data management system may capture the in vivo and ClinPath data, but maybe not the TK analyses or the ECG data. So those may come from separate data management systems, and they can the data can be transferred over to the Send system either via CSV or via web services. So for example, if you have Watson or Panema, you have options on how to get the data over to your Send system. The Send system then takes the approach of transforming the data into the appropriate domains, into the appropriate data sets, creates your non-study data reviewer's guide, which is basically a Word document that describes study and all the components. And this is a Word formatted version. And you have as well as a validation aspect where we're going to verify that the data sets are compliant to all the rules before you submit them. So you end up with a validated output package. This strategy is somewhat, I'm oversimplifying it, but it is much less complex than a strategy where you have different service providers and different data management systems associated in aggregating and getting you the data. In the first example with a complete data management system, you have a method that you can validate and verify in advance that it works and on a regular basis. When you have disparate systems, you may have more than one CRO partner. You may have, and each CRO partner may have a different way of collecting the data, a different way of doing their business. So you have to start thinking, where is my data? What data am I collecting for this particular study? I have in-life data, post-mortem data. Very commonly, the in-life might have been done at one CRO. The post-mortem may be done by a pathology experts, okay? So how do you then create one data set? Okay, you got to think, where's all my data coming from? As well, you have TK data, which again may be by yet another provider or one of the first two, and then ECG data as well. So, and we're sharing with you some of our own challenges, because when we're doing this as a service, we have to get an understanding. We have to basically create a roadmap for ourselves of what we are expecting from where and from whom. Okay, and we try to actually make up some check sheets, some checklists of what to expect, what format to expect it in. We interview the clients. You should be interviewing your partners, your CRO partners, your service providers, and find out, are you getting data paper, PDF, spreadsheets, a system export? May not be a spreadsheet, but could be an still an electronically formatted data set. Or you need to sort of organize yourself. This is what I demand from my partner, and even potentially give them a template by which they can provide you the data. So if there's a nice, easy way to accelerate or simplify the method by which you import the data, you might actually want to give that template to your service provider and have them fill in the data that way. Then you have to understand and get an understanding of all the transformations that need to happen. Assuming that you're getting data from various systems or from various service providers, you have to look at details such as date and time format. Or are you using day month or month day? Are you including 24-hour clock, or are you including the 12-hour clock? The animal IDs, again, if you had one service provider doing the in-life and another service provider doing the post-mortem, you better make sure that all of the animal IDs correspond, and then will have to be transformed into the subject IDs. And you also need to understand how the data has been pooled. So again, if you had clinical observations being done by cage, you need to understand which animals were in the cage at the time. Okay, so some of those details are required, and commonly you're not going to get them up front. You'll have to ask for them. Okay, so again, if you set up a list of things to ask for and a template by which they should be provided, you will simplify your approach in terms of getting a good set and getting accelerating the development of the SEND data set. You then load or utilize the tools, your SEND tool set, to load that data into the database in order to be transformed. But there's things you need to then worry about. when you need to understand, where all the lab units. Well, we'll actually start in chronological here, order. You need to understand the tissues and specimens names used. Were they using adrenal gland, or were they using gland, adrenal? And had a map from the data collection aspect, the data that was entered during the conduct of the study, versus the data that must be then submitted. Okay, because there are approved terminologies to be used. Same is true for the lab tests. Did you use urine glucose, or did you use glucose, urine? The micropathology findings, that is near and dear to my heart, because pathologists seem to like calling things a lot of their own way. So you have to take a look or have an understanding of the data as it's coming in. Even if it's coming in a perfect format, it then needs some analysis in terms of understanding the relationship between the data as it's been transferred to you and the data as it needs to be exported out. And that's done through mapping. And now I'm going to hand over the microphone to Bob Friedman, who's going to take you through the rest of these, or a number of these next steps.
Okay, hi. Can you hear me, Carlos?
I can.
Okay, so what I was going to describe is these next set of parts of the process, and I'll see if I can catch up a little on time, because we don't want to miss out on either demo or Q&A time. So the way we look at the data is to make sure that we are able to compare it from the study report, which is still given in its narrative PDF format, and the SEND data sets. And so we need to, in the end, make sure that the data is going the same to the FDA, as the FDA is using more and more the electronic data sets. We still have to make sure that the data is corresponding to what's in the study data report, and that the data accurately portrays the collection, so that the analysis is going to be correct and match what was in the study data report. So we think about the checkpoints here. If we're loading data into a SEND system, that this ETL, we need to check that the ETL is being done correctly and any transformations that it's making, and that once it's in the system, that we can check the data within that system. At the output time, we then have these deliverables that are created. If you are manually entering data into a SEND system, you probably need to do 100% check on manual entry. Sometimes in the clinical world, this is done as a double entry. We hope that most of this is automatic. We certainly plan for it to be automatic, so we could validate the system rather than each individual data point. We then still run the output through a validator. This is going to check against both business rules that the FDA expects and conformance rules of the SEND data set. And we need to resolve any errors that come out of the validator and explain any warnings. So as we've experienced this, and this is also information that's been collected from the FUSE community. So if you're not a member of FUSE, I suggest that everybody joins that. FUSE is a user group which is very heavily focused in the non-clinical portion on the SEND submission. And then once that's in hand, what else can you do with the SEND data? But the concern in the submission, again, is that the SEND data sets represent the study design and the data collected. And you could get differences that between the reported final study report and the SEND data space. And we need to control these differences and prevent any significant differences from going out. This comes about because historically across the industry, we have data capture systems that have been developed over the past couple of decades. They go through a reporting process that's been developed in parallel, and the SEND data sets have been primarily a later addition. And so we hope that there's a great overlap, but it's not a complete overlap between these systems. And so the data being handled differently, it has the opportunity to become different. So some of this information is available from there was a Fuse group that studies the discrepancies between the study data report and the data sets. And so this is their recommendations, that you think of this as two types of discrepancies. There may be low impact discrepancies where this will not affect the interpretation. These may be things like pretest data may be in the data sets for the SEND, but it may not be in the study report if this was not consequential. Sometimes you're just pulling out the baseline data that may only represent either the initial observation, for instance, in clinical pathology, or it may represent pretest data. The SEND data set may have multiple values. The study data report may not have that at all. If this is not consequential to the analysis of the study, then you still can explain it in the study data reviewer guide. A high impact discrepancy would be that it's going to affect the data, and these need to be either reconciled or very carefully described in the study data reviewer guide. Areas here that have caused trouble with submissions, where the FDA has brought feedback of questions about submissions, are pathology data not matching up because of base finding names and modifiers being different between the two types of the representation of the data, or the severities. The severities has been of a particular issue because of grading systems. If grading systems are on a scale of 4 grades or 5 grades, and this is not absolutely clear, or it's actually represented differently between the study report and the data set, this causes great consternation to the reviewers because of the criticality of the micropathology severity grades in analyzing the toxicity. The recent control terminology makes it very clear that you need to represent your grades on a scale. So if your scale is 1 to 5 and you've set it a 4, then the severity is really called out as this is 4 out of 5. This is to control this problem that occurred before, where studies were given and a grade of a 4 was introduced, but the reviewer couldn't tell if it was 4 out of 5 or 4 out of 4, and the study report might have had it one way, and the SEND data set was being pushed into using what was the terminology of a 5-grade system previously. The control terminology now has 1 of 3, 1 of 4, 1 of 5. It can be very explicitly described. So there you come to a cycle where you're looking at your study data report, you're finding these discrepancies, and then you need to reconcile them or explain them, and then look to both experts and your vendors to reduce these discrepancies for the next go-around. So other stumbling blocks that have been encountered, and these have been found through a survey that we're involved in as well. There's a Fuse survey that's done annually that's brought up some of these stumbling blocks. These are found by the FDA as well, and the FDA puts out their technical conformance guide to tell people how to represent the data better for their analysis. So one particular issue was that if you have pharmacokinetic concentrations and you have analysis which is below the level of quantification, how do you actually use that in your summarization? Did you represent them as 0? Did you discount them? Did you represent them as half the lower limit? So these things now have instructions in the technical conformance guide as to how to better represent these. There is a great deal of rules to be followed. There's the SEND implementation guide, there's the validator rules, there's the technical conformance guide. And so it is a lot of effort to keep up with all these things. And that needs to be done, and the time has to be put in as well to check when these documents get updated. So I will just show here where there are resources, and we'll make this available as part of the slide presentation. The FDA's official location, the data standards catalog, tells you what versions are required by what dates of SEND data sets. The electronic submission guide gives you the overall of how to prepare it. The technical conformance guide changes more often. That's come out in October, and it gives information with these kind of technical aspects that the FDA has had trouble with and how they want people to submit in a clearer format. And then CDIS publishes the actual standard, the IG 3.0 and the IG 3.1 can be found here. The Fuse group puts out a lot of information. There's an implementation forum, there's an implementation wiki. There were specific papers that were written on data consistency and on things like biomarkers and anti-drug antibodies that were presented as either papers or posters that have information that you can now look to. And they also have listed the template for creating this study data reviewer guide. So I did want to spend a little time doing a demo. The time is flying by here, but the system that we use to create this is the Zybion Savant system. So I will just show this briefly. So Savant is our mechanism of creating the SEND data sets. What this allows you to do is gather your data into a location and then output the SEND data sets from here. We can bring in data that is either coming from our own data collection system, Pristima, or we can bring in data that's coming from other systems through either CSV files or portions that may already be in XPT files. So what I could do here is put in my credentials to the data collection system. I could pick a study that that system has, and I could then bring that in. What it'll do is it'll transform the data from the data collection terminology into the needed SEND terminology. And it'll also do control terminology mapping so that the data output is in the terms for the NCI. We'll give it a minute here. As it's pulling in the data, it's also bringing in the trial summary information. I have an opportunity to rename the study because the study at data collection may be different than the sponsor's final name for the study. It brings in information about the animals to create the demographic records, and then converts what might have been the data collection system's dose groups and phases into these trial arms and sets that are used by SEND. We then create a control terminology mapping. There are about 78 lists that we track. Some of them come very full from the SEND standard with many choices in them. Some of them, in fact, come empty in that there are no standards or very few standards for the clinical observation data set. But if you look here under the specifications, the mappings that we're doing are to ensure that the wordings used in data collection are then properly transferred to what's expected in the standard. So if we look at something here like, if we look for liver, we see that the ability here is not just adding the name of the specimen or the tissue here as liver, but we need to transform that if the data came in the data set as a liver, dorsal on the left side, partial, and this is how it was read by the pathologist. And what he's describing is the specimen that he's looking at. However, we need to break this out for send output and say that, well, actually, the specimen is liver. However, the directionality was dorsal, the laterality was on the left, it was a partial, there might have been an anatomical region as well, to separate these out so that the data is conforming to the expected standard and that each item is in the proper bucket. So we do this as part of our setup so that in the end, the data output is going to be properly transformed. So I do that here to output the data. I select the study that I want to output here, and I can then choose, do I want to put this out as 3.0 or 3.1? Do I have, if it's 3.1, whether it includes the reproduction data domains as well, if this was a DART study, what version of the define file to create, and then I can do this periodically as well. There are CROs that we're working with who want to output send data sets during in-life on a very long study once a month, and then once pathology is ready, in order to get this to the study monitors at the sponsors more frequently, even though that the final submission, of course, has to wait until the study is done and reviewed. This allows an interim transmission of the data for review purposes and for study monitoring. We do also encounter that you're bringing in data that you need to combine data that may be available in different departments. And so one example here might be if you're getting your EG data, and your EG data might come to you even in an Excel file or a CSV file, and it may not have all the needed attributes. So I can get a set of EG data, but it might be missing reference dates to the exposure reference, and that is needed in the send data sets. So the way we handle this is when we bring the data into our system, that we merge it in to include the reference dates from the exposure domains. And so we do that here in our system, that we can bring in additional measurement loading. We can bring in from any of the data sets types that are available. I could bring in the EG data. I can give the file name that it's coming in as, and I could also transform it on input and combine it with other information like the reference dates with the exposure reference dates. Our final step is to create this study data reviewer guide, and we do this through our output at the same time. It creates a template of the study data reviewer guide. It also creates the defined file as well at the same time. So if I look at one that I had brought up previously, if I get to my output here, the defined file is, as Carlos had said, kind of an index for your whole study. It can look like this. Each one of these is the domain data. If I look, for instance, I can click on the electrocardiogram data. This will bring it up here in this SAS viewer format, and I could see if I've done my merging that I'll be able to get as well my the raw data as well as the reference date and the reference dosing correctly into the set. We also need to create the study data reviewer guide, so that's brought in here as well with a link to that in the define file. This is created as a template, and then it does require some human interaction. We could fill out what study it is. We can fill out the trial design that was drawn from the study data records. We can bring in what versions of standards were used and the data sets. But then there's a place here for putting in additional narrative describing either any discrepancies or explaining any warnings that might exist within the study output. So it's important to use the template that the Fuse group has created, but then to update it with information during the creation of the study, and then any special information that has to be brought to the reviewers. So I did want to stop there with the demo. I'm sorry if I was rushing there, and turn it to Avanish, who is going to talk a bit about the how we improve the validation of the data coming out.
Thank you, Bob. Bob, can you take me to the next slide, please? So everyone, what we just saw was that the send submission do work. So it's not something new. But at the same time, we realized that there's plenty of pain points. So there were multiple slides which you saw where Bob and Carlos discussed the concerns. So let's try to divide it into three portions. So first is how do we see the current processes related to the intake of data, the collection systems. So one thing is there was a divergence. So these systems are legacy systems created many years ago. There's the specification for send is getting evolved every year. So there is definitely a diversion there. So there is not sufficient validation logic which is already applied during the data capture in some of the systems. And the data transport which is happening to the send producing system is not really finalized. There is not really a one way to kind of get that thing done, because that's an after the fact process. And anybody who is collecting the data, if they are doing a typo or there is some data which needs to be collected and not being collected, so there is a lack of real-time feedback just because the systems are not really integrated well enough, and the send is not the first-class thought when we are doing it. So there are some challenges in those intake processes. The second one is the preload validation. So when the data comes to the send producing system, as you saw in the demonstration, there are ways we need to pull the data, we need to do the transformation, we need to still verify if the date formats are correct. So there are many things which needs to be done before the preload. And at the same time, we also need to deal with multiple file formats. So there can be data in flat files, CSVs. Sometimes it can be coming directly from the other system by a push mechanism to our APIs, or they will be putting it to other systems so that we can pull the data in. So there are plenty of variability there. And many of those steps are still manual. Now, assuming that till point we did our processes and now we created the submission files. So let's look at the third issue. Even before you submit, it needs to go through, again, similar validation processes. People need to look into it to be really sure that it conforms to everything which is required for submission. I looked into a couple of rules, and just to give you an idea about the volume of rules which needs to be run is 80 plus business rules, 450 plus validator rules. That's plenty of checks which we need to do. And this entire process is, if done manually, is very error prone, labor intensive, and costly. So think about a day of delay in the approval. It's like a day of delay in when you go to the market. So that's plenty of money lost for every delay. So net, what you see is that current processes do work, but there is plenty of labor involved, delays, and costly process. So how do we use the technology which is today to kind of enhance on it and increase our efficiency? So this is one of the proposed architecture which which we are trying to implement into our system. First, in the left-hand side, what you see is there must be a consistent and secure way to get the data into the send producing systems. So example, one of the push ways to get the data is the producing systems can push it on the online portal securely or put it on the secure FTPs. Another pull way is that we can have adapters connected to different producing systems, and we can get it as soon as the data is available. Right-hand side in the middle bottom area, you see the validation API. That's the key, the blue icon, that's the key which we are proposing, because this is the bulk of the validation. And the validation is not only on the simple data sets, it's really on the flat files and, for example, the PDFs. So how do we really get the data, which is non-structured data, and try to convert it into a structured data? Example, you saw some of the things about the liver, dorsal. So the systems can now really identify that which one is directional and what kind of synonyms are similar to liver. So we, as human beings, do not need to really worry about those as of today. So in the new technology world, we use machine learning to kind of solve those problems. So the two proposals here is that first, before it gets ingested to the send mapping engine, we do our pre-validation rules, send out a report to the original data source stakeholders. After we do the mapping and we do the submission files, at that time, again, we use machine learning to kind of create the reports and send it back to the stakeholders. So that the process, the feedback process is really minimized. And as soon as we do that, the entire process from data collection to the submission, that can be cut into a very short time compared to what we do today. Okay, so going to the next slide. So net, what we will be able to achieve is that the intake processes will be improved. We all as a community needs to either export the data. We need to make sure that all the systems should be able to export the data correctly, or there is an adapter which is able to pull the data from that. Having a central API to validate at every stage of the data intake, pre-validation and post-validation will make things consistent, and it will make the process a lot shorter. So net, if we do follow these recommendations, the processes will be automated, that this will be less labor intensive, things will work on time. And being the rules, being the central API, once there is a new rule come in, we just put it in that central place without even touching all the systems which are using those rule validators. So that way things will become very effective. Okay, so that's a quick introduction of how technology can help us get to a shorter time. Thank you, Bob.
Okay, so I think we're actually don't have a lot of time left. However, we are at the Q&A period. I don't see any questions in the chat or the questions section. Is that right, Nagaraj?
There were some hands raised, and I think people can raise their hands again to re-ask questions.
Yeah, the floor is open for questions.
Yeah. On my part, I did want to clarify one thing. When I mentioned the record of new drug approvals, it was an all-time record. I just had it in my mind. I remember a chart that only covered like 2000s, but it was an all-time record last year. And as far as the demonstration is concerned, we recognize that we went very quickly through demonstration. For any of you who want to see a more detailed demonstration, please reach out to us, okay? Just wanted to get that in before the questions.
Yeah, Carlos, we have a question from Bill Hauser from BMS.
Yep.
What strategy do you recommend to overcome the validation concerns about machine learning?
Sure. So one of the things which we do is have different kind of ways to understand these files and do some data extraction mechanism using machine learning. Example, if you have a 20-page PDF file with plenty of data inside, so which data point is useful? You train the system to pick those every time when the same data set is coming from the same source. So that way, it gets a repeatedly successful process instead of being manually getting validated every time.
And I see that Cheryl has her hand raised.
Yes, and we have second question here from Nazneen from Lasa Limited. She would like to know what are the issues you are trying to resolve with the machine learning process.
So primarily the issues are we are trying to reduce any of the manual work which needs to be done, and on the fly if we need to change any of the mappings the way we demonstrated in one of the screens. So those things can be immediately resolved using machine learning. So it will cut the manual process in the entire workflow.
Just to expand on that, if you have data coming from various sources and are doing, whether it's 100% QCs or any kind of percent QCs, you can automate some of this testing to verify the data or to actually compare the data on the way in to the data on the way out to make sure that, in fact, you've covered all the data points, that all the transformations have occurred, and that no data was actually lost in the process or transformed the wrong way. So a number of these steps are actually being performed and checked manually, and we want to basically automate that process.
And there has been some research done on the clinical end of submissions. Now the clinical is a bit of a different issue because they get data from a lot of points around the country where the forms are being filled out by doctors in remote locations. But the work that they're doing is to look into outliers and to flag outliers in certain types of measurements as being potentially wrong, and then a person could look at them. So it's another approach as well, which is to look for things that are either unusual, high values, low values, values that are, let's say, too precise, or the wrong number of decimal points, looking for these types of outliers, and then to bring those to an attention as a possible error in the database.
Cheryl, did you have a question? You had your hand raised for a while.
No, she said she didn't have questions at this time. Yeah.
Okay. Just saw the hand raised.
Okay, well, very good. I think we're at the top of our hour here, which was the scheduled time. So I certainly appreciate everybody's attendance, and we will make available recording and the slides. And as Carlos said, if you want more in-depth demonstration of our software, you can contact him.
Bob, we have a follow-up question from Bill, BMS. He's asking, is machine learning used only for quality control or also other purposes?
In this case, so one aspect was the quality control, and another aspect was more onto the transformation side. So transformation side is still done using the tools which we demonstrated, but that can also be automated using machine learning.
Yeah, on our part, we were looking to get the most bang for the buck, and where we're spending a significant amount of time is doing a lot of this QC checking. So if we can automate this, there's a quick and reasonable return on investment.
Okay, we have one more question, Nazneen, asking about familiarity with eTranssafe project.
So my understanding is that the eTranssafe is a project that is going on in Europe to combine historical data from multiple companies, and they are looking at the send mechanism as a way to contribute data into that. There's also a US consortium, which is the Biocelerate, which is doing a similar thing. We've not been directly involved in that. Some of our customers have, as they are the sponsors that own the data.
Any more questions from the attendees? Okay, I think at this point we have no more questions. As Bob indicated, we'll make this slide deck and the video of the recording available to all registered attendees. And we thank you for your time today for this webinar. It's a very important milestone that we will be approaching in March. We hope that this webinar was informative and useful to you. We welcome any feedback to Zybion in terms of the webinar or in terms of the subject matter. Thank you very much for your time and have a good day. Thank you very much.